Welcome to GSA's webinar, the 2025 Alzheimer's Disease Facts and Figures Report. We're so excited to have you with us today. Next, we have a few housekeeping items to go through. Please type your questions in the Q&A box at any time during the webinar. A Q&A session will be hosted immediately following the live presentations. Our program today is being recorded and will be available on demand at GSA Enrich by the end of today. Your feedback is very important to us. Please complete the evaluation following the webinar. I'm excited today to introduce our two speakers. The first speaker is Matthew Baumgart. Matthew is a Senior Vice President of Health Policy for the Alzheimer's Association, leading a range of products and projects at the intersection of policy and programs. He oversees much of the association's public health work, including 2 grant programs funded by the Centers for Disease Control and Prevention, and the association's programmatic risk reduction efforts. In addition, Baumgart directs the association's global public policy efforts, working in collaboration with Alzheimer's Disease International, the World Dementia Council, and the World Health Organization. Mr. Baumgart joined the association in 2009 and has served in roles overseeing policy development, public health policy initiatives, federal affairs, and state government affairs. Prior to joining the association, Mr. Baumgart spent nearly 20 years working in the U.S. Senate, including as a legislative director for Senator Barbara Boxer, and also a legislative assistant for over a decade to Senator Joe Biden. So we're very happy to have you today, Matthew. And I'm also pleased to announce our second speaker, Dr. Elizabeth Edgerly. Dr. Edgerly serves as a Senior Director of Community Programs and Services at the Alzheimer's Association, where she oversees nationwide initiatives that support individuals living with Alzheimer's disease and other dementias, as well as their families. A seasoned leader within the association, Dr. Edgerly is also a licensed clinical psychologist with a specialization in geropsychology. Since joining the association in 1995 as Chief Program Officer for Northern California, Dr. Edgerly's managed a wide range of care and support programs for individuals with dementia, their families, and healthcare professionals. In 2016, she was appointed the Executive Director for Northern California and Northern Nevada. In 2017, she expanded her role as Regional Vice President, overseeing operations in Arizona, Nevada, and Hawaii. In 2024, she took the role as Senior Director with the association, overseeing community programs nationwide. So based on these bios, we have 2 amazing speakers today, and I'm going to turn it over to our first speaker, Matthew Baumgart. Matthew?
Thank you very much, Lisa. I really appreciate the opportunity to present today, and thank you all for joining us as we review the highlights of the 2024 Alzheimer's Disease Facts and Figures report that's put out by the Alzheimer's Association. This is an annual report, and every year we explore the burden of Alzheimer's and dementia, whether that's on society, government, the healthcare system, as well as individuals and caregivers. Each year there are standard sections of the report that I will be going through, sections on the prevalence, on mortality and morbidity, on paid and unpaid caregivers in the workforce, as well as the costs of Alzheimer's. And then every year we have what we call a special report, the last chapter of the book, if you will. And this year it was on American Perspectives on Early Detection of Alzheimer's Disease. Now that there are treatments that have been approved by the FDA, what does that mean for early detection and Americans' attitudes toward early detection? And Elizabeth is going to be delving into that for you during today's presentation. I should say we cannot cover everything. Alzheimer's Facts and Figures report is 148 pages, so I encourage you to take a look at the report, and it's very, very tiny print. If I didn't have glasses, I would need them. There's a lot of stuff in that, and we're only covering a very, very, very small portion of it, but we did want to give you the highlights and encourage you to explore more on your own. So I'll go ahead and start with our usual main sections of the report, beginning with prevalence. For the first time, Alzheimer's disease prevalence has topped 7 million people in the United States. An estimated 7.2 million older adults are living with Alzheimer's in the United States. And a fun fact, I'm adding in a fun fact as a bonus for you joining this webinar. This is actually not in facts and figures, but the number of older adults with Alzheimer's disease today is more than twice as many total number of seniors that were alive in the United States in 1900. So think about that. There are twice as many people with Alzheimer's as the entire senior population was 125 years ago. And it's not going to get any better without further advances in treatments or preventions. The estimated number of Americans living with Alzheimer's will reach nearly 13 million by mid-century and will nearly double this year's estimate by 2060. Now, everyone is at risk of getting Alzheimer's disease, but it does not hit everyone the same. Almost 2/3 of Americans with Alzheimer's are women. And you can see the graph on the left, the lifetime risk at the age of 45 and 65, compared with women versus men. The risk at age 65 is considerably higher to develop Alzheimer's for a woman than it is to develop breast cancer. Older Black Americans are about twice as likely to develop Alzheimer's disease, and Hispanic Americans are about 1.5 times more likely to develop the disease than are white Americans. Alzheimer's disease continues to be a significant cause of death in the United States. The data from 2022, which was the latest year that was available when we went to print, showed that more than 120,000 Americans officially died from Alzheimer's disease that year. There are studies that show Alzheimer's disease tends to be underreported on death certificates, so that number is probably lower than reality. But more than 120,000 Americans officially died of the disease in 2022. Between 2000 and 2022, you can see on the right that the number of people who died from Alzheimer's has risen 142%, while many other causes of death have either decreased or stayed relatively flat. You can see some of those diseases on the chart, including heart disease, which is the #1 killer in America, has declined slightly over the last 22 years. Alzheimer's disease was the 6th leading cause of death among Americans 65 and older in 2022. Overall, it was the 7th leading cause of death because of COVID. But COVID's numbers were 2020, 2021, and 2022. And then COVID deaths in 2023 dropped significantly. That data was not available when we went to press. But in fact, in 2023, Alzheimer's will be back up to the pre-COVID level of being the 6th leading cause of death overall in America. So mortality is just one indicator of the burden that Alzheimer's disease places on society, on individuals and families. There's also a lot of other burden that it places. Alzheimer's disease begins about 20 years or even more in some cases before the onset of symptoms. That is, the brain changes associated with Alzheimer's begin long before symptoms. People age 65 and over survive an average of 4 to 8 years after a diagnosis. But as many of you who may have had a loved one with the disease know, sometimes that can last as long as 20 years, a person living with the disease after a diagnosis. At the age of 80, approximately 75% of people with Alzheimer's dementia live in a nursing home, and that compares with only 4% of the general population at age 80. So you can see the big burden this disease places on the long-term care system. So in terms of caregiving, in this section of our facts and figures report is about unpaid caregiving. Last year in 2024, nearly 12 million caregivers provided over 19 billion hours of unpaid care to someone with dementia. The economic value of that care is estimated at more than $413 billion. And to put that amount into perspective, because that's a lot of money. So to put it into perspective, that $413 billion, the economic value of unpaid care, is 16 times the total annual revenue of McDonald's. So who are the caregivers? Well, 2/3 of the caregivers are women, and 1/3 of caregivers are daughters. So just as we saw under the prevalence section, women are more likely to have the disease, they're also significantly more likely to be caregivers of someone with the disease. About 1 in 3 caregivers is age 65 or older, and this is often surprising to a lot of people because we tend to think of the caregiver of someone with Alzheimer's being that person's spouse, and therefore most likely also over the age of 65. But in fact, only 1 in 3 caregivers is an older adult. Most caregivers are middle-aged, taking care of their parents. And in fact, 1/4 of them are not only taking care of an aging parent with dementia, but they're also caring for a minor child, that so-called sandwich generation caregivers. Now, caregiving exacts a big toll on caregiving, and there are a lot of stats in facts and figures about the financial, the economic, and the healthcare toll that dementia caregiving can take. So I encourage you to go to the document itself to learn more. I put a couple of stats up here just to illustrate some of the health effects. Spousal dementia caregivers are 41% more likely than other spousal caregivers. So this is comparing caregivers to caregivers, but they're 41% more likely to become frail during their time as caregivers. And that a lot of that has to do with the type of care and the intensity of care that is required for dementia caregiving. And more than 1/4 of dementia caregivers say they delay or do not do things they should to maintain their own health. And another little fun fact that's not in facts and figures, the Alzheimer's Association, as part of our work as the Public Health Center of Excellence on Dementia Caregiving, funded by the CDC, along with the Center of Excellence on Dementia Caregiving at the University of Minnesota, released a report in June that found that dementia caregivers, especially younger dementia caregivers, those under the age of 45, are more likely than the population overall to have health conditions that are risk factors for dementia. So switching from the unpaid caregivers to the paid workforce, as prevalence of Alzheimer's increases, so does the need for a paid workforce that is involved in diagnosing, treating, and caring for those with the disease. First, taking a look at the direct care workforce, that is home health aides, personal care aides, nursing home workers. By 2032, it is estimated that nearly 900,000 additional direct care workers will be needed over the 2022 levels in order to meet the growing demand for services. And that's more new workers than in any other single occupation in the United States. Between 2014 and 2023, the number of direct care workers in the United States increased from 3.5 million to 5 million. This job growth reflects more preferences for aging in place, which I know many of you have worked on, as well as public policies that have expanded access and placed greater emphasis on home and community-based services. But again, this was, although that was a sizable increase in the number of direct care workers, these employment projections fall short of the true workforce demand. As you saw on the previous slide, another 900,000 are going to be needed by 2032, and turnover rates in this industry remain incredibly high. It's estimated that there's an 80% annual turnover rate for direct care workers and a 99% annual turnover rate for nursing assistants in nursing homes. Turning now to the medical side of the equation, there are shortages in the medical provision of care and medical specialists, which creates barriers to timely and accurate diagnoses and can result in delays in accessing treatments, whether that be pharmacological treatments, the new ones that have just been approved, or non-pharmacological treatments. A delay in getting access to those treatments is often caused by shortages in medical providers. It's estimated that up to 59% of those age 65 and older live in an area with a dementia specialist shortfall. Neurologists are in particular, and perhaps you've heard the term neurology deserts, which many places in America are not enough specialists to meet the need. And it's estimated that more than 18,000 geriatricians will be needed to care for nearly 13 million individuals projected to have Alzheimer's dementia in 2050, and that's more than double the number who were practicing in 2021. The final section of our main report is on the costs of care and the economic burden that Alzheimer's places on America. This year, the total health and long-term care costs for individuals with Alzheimer's and other dementias is estimated to be $384 billion. That's $24 billion higher than last year's estimate. And you can see on this slide that total cost is projected to reach nearly $1 trillion by mid-century. On the right side of the screen, you can see how those costs break out. Just note that Medicare and Medicaid, so that's taxpayer dollars, the two government programs combined, they cover almost 2/3 of the cost, $246 billion of that $384 billion. But out-of-pocket costs are still extremely high and still burdensome to families. A quarter of the costs of caring for people with Alzheimer's are paid out of pocket by family members. So before I pass the baton to Elizabeth to talk about our special report, I just thought I'd pause and share with you some of my takeaways from the data in this year's report. So first of all, without a significant growth in the direct care workforce, a larger and larger burden is going to be placed on dementia caregivers. And this really highlights the need for a greater investment in community support. I think we must not forget about the health of caregivers. When we talk about caregiver needs, we often talk about support for caregivers, relief for caregivers. We talk about things like home health aides, home health care, adult daycare. But let's not forget about the health of caregivers. It creates a burden on them. And as I mentioned, the new report that showed they actually have more risk factors for dementia themselves than the population as a whole. Primary care physicians clearly need to play a bigger role, but they need to be better trained and educated. A very large number of primary care providers, you can read more about it in the report, but a large percentage of them said they received little to no education and training on Alzheimer's when they were in medical school or during their residencies. Brain health, that is addressing risk factors, we must start doing that as people age, not when they are aged, and this must become a primary focus. We must start talking about brain health to people who are in middle age and younger, and not just waiting, because Alzheimer's is an older person's disease. We shouldn't be waiting to talk about keeping your brain healthy until people are older. And I say this because we need to do this if only to keep the problem from getting worse. If you remember, when I was talking about prevalence, I showed the graph that showed the projections of where we're headed by 2050 and 2060 in terms of the number of Americans living with Alzheimer's, almost 14 million by 2060. Those projections are based almost solely on demographics of the population and the changing demographics of the population. They use as a base current or recent cohorts of seniors. and current and recent cohorts of seniors had much lower rates of obesity and diabetes than people who are middle-aged today and will be our future seniors. So if diabetes and obesity are causal risk factors for dementia, and that's still an if, we understand there are connections and linkages. We don't understand the causation yet. But if those two things are causal risk factors for dementia, tomorrow's seniors are going to have a lot more of that than the seniors that were used to make the future projections. Specifically, diabetes among the population today is 8 times higher than the population when today's seniors were middle-aged. And obesity is 3 times more common today than it was when today's seniors were middle-aged. So if those things are playing a role here, the projections could be underestimates moving forward, and we've got to invest on the preventive side of the equation in brain health. And that circles back to the importance of public health efforts. I'm a bit biased here because that's part of my job, is to work on our public health work in this space. It is really a public health crisis, and public health efforts are really needed for those two areas that I think public health is particularly good at, and that's promoting health, in this case, promoting brain health, and encouraging and promoting early detection and diagnosis. So those are some of my thoughts. Those are my thoughts and not necessarily the views of the Alzheimer's Association, as they sometimes say on television. And with that, I'm going to turn it over to Elizabeth to talk about our special report.
Thanks, Matthew. I have to say, I've heard Matthew do this presentation a few times, and I will say it's like this weight when I see the statistics, even though I know them pretty well by now, when you see the numbers growing, the costs, the toll, and then Matthew, when you drop that last bomb right there where you're like, oh yeah, and the numbers are based on the older generation who doesn't have as much diabetes as the ones that are going to age. I thought, oh man, this is rough, right? So, what I am so pleased to get to share with you is our special report. And I would assert that it shows some optimism and promise for the future, that maybe, just maybe, we will actually be able to see this trajectory altered in the next 10 years, 15, who knows how many years, but um, it's really something to see. So let's talk about the special report. Every year, the Alzheimer's Association does a study to look at some aspect of what we're seeing unfold before us. And this year, it's the American Perspectives on Early Detection of Alzheimer's Disease in the Era of Treatment. What we did is we looked at Americans' awareness and their attitudes about not only early detection, but also diagnosis of Alzheimer's, testing, what they thought about different types of tests for Alzheimer's, and also what about the treatments and their own decision making as to whether or not they would be willing to accept some risks with new treatments. So as you can tell, I'm pretty excited about this year's report. It's the first comprehensive survey to look at how Americans view the new treatments. And I'm talking specifically about the disease-modifying treatments that, at least at present, are targeting amyloid. It's really timely. Since this report came out, a new blood test has received FDA approval. And so the things that I'm going to be talking to you about are really, really relevant and have already changed since the report was released. So with that, Matthew, let's go to the next slide. And just to kind of outline how we did this nationwide survey. So there were over 1,700 Americans age 45 and older, and we identified a full sample, including a diverse sample of individuals to try to be representative of the diversity in the United States. The survey was offered in English and in Spanish, and both online and by phone. And what we looked at specifically were knowledge gaps, awareness, and attitudes towards what I just mentioned, early detection and diagnosis, diagnostic testing, anti-amyloid treatments, and what the future looks like. Go ahead, Matthew. So here are the overarching takeaways. We heard loud and clear that Americans want to know early if they have Alzheimer's and they would like access to testing. So look at these numbers. Almost 4 out of 5 Americans, 79%, indicated they would want to know if they had Alzheimer's before the symptoms appear or if they're mild, so before they start affecting their daily activities. More than 9 out of 10 surveyed indicated they would like a simple test, like a blood-based biomarker, if it were available. And again, this survey was done before a blood-based biomarker was FDA approved. If diagnosed with Alzheimer's, most Americans would want to access medication to slow the progression. And they indicated that they would highly value information about the disease and treatment. Not too surprising there. So look at these statistics. More than 9 in 10, 92% said they would probably or definitely want to take a medication to slow the progression of the disease following a diagnosis. That's huge. Let's just stop there. 92% of people is really significant. Nearly 3 in 5, 58% indicated willingness to accept some risk. And what we're talking about is moderate to high levels of risk involved in taking that medication. And they also indicated, as I mentioned a moment ago, a strong desire to receive more information about treatments that slow the progression of the disease, 72%. So let me just pause for a second, because so often I am privy to these conversations where people say, gosh, would you even want to know? Or what are you going to do if you find out you do have Alzheimer's? And what we're seeing in these data is a shift in that attitude. And so you, depending on what your role is, you may have the opportunity to share information to help people see that there are some new options for them shaping up. Matthew? So here were the concerns that we heard voiced in this survey. The number one concern about biomarker testing was money. Insurance coverage came out as the top concern, followed by accuracy, and then the cost. So the first concern was, is insurance going to cover my future care and treatment? And is insurance going to cover the testing cost? We also had some concerns voiced around accuracy, cost, as I mentioned. This next one's interesting: potential to lose confidence in one's abilities and not be able to do certain things like work, continue working, or to be able to drive. But what we also saw was that the Americans surveyed want to help advance science by participating in Alzheimer's research. We heard a lot of optimism and interest in clinical trials. So 83% indicated they would be willing to participate in a clinical trial for treatment following a diagnosis. They also expressed optimism that there will be new treatments to slow, prevent, or even cure the disease. So we saw 4 out of 5 Americans expressing optimism around this. And I have to say, Matthew and I just came back from our international conference. AAIC was in Toronto. And I don't know about you, Matthew, but I'm always optimistic after I go to AAIC, but I have to say this year, hearing more about what seems like it could be in our future, I thought, oh my gosh, I think it's actually really happening. That I think there are going to be some additional treatments, some new pathways, and some new strategies even for drug delivery and biomarkers. It is a very exciting time in Alzheimer's research, an important time to continue investing in Alzheimer's research, I would say as well. Next slide. So here's some of the data, the specifics. What we saw in our survey was people indicated that early diagnosis is important to them. So what we can see is that people overwhelmingly express that early diagnosis of Alzheimer's is important. And in fact, we saw 79%, you can see the purple bar, indicates that early diagnosis is very important. And then another 20% indicate it's somewhat important. So that's 99%. It's hard to get 99% of people to agree, but this is something they agree to. And I would assert that people wouldn't have agreed to that always. We often heard like, why are you doing early diagnosis? But keep in mind, we're now in the situation, in the era of treatment where people have an opportunity to maybe do something to change the trajectory of the disease. Next slide. The next slide is interesting because it perhaps shows how Americans' mindsets are changing, as I've been talking about. So our survey found that nearly 4 in 5 Americans would want to know if they had Alzheimer's before symptoms appear or before symptoms start to really affect their daily living. And you can see that by these bars on the left-hand side, which combined equals 79%. So that's I'd want to know if the symptoms were mild or even before the symptoms occur. So again, that is a significant shift from not that long ago, I would say even less than 5 years ago, when many people indicated hesitation, frankly, on the part of doctors to diagnose, and for individuals to express hesitation about wanting to know and wanting to pursue that. So in order for us to get to these diseases early and even ideally before symptoms occur, this shift in mindset is a key part of that equation. After the next aspect that we looked at was whether or not people would be open to testing. And so you can see in these two graphs, we have interest in pre-symptomatic Alzheimer's disease testing and then post-symptomatic Alzheimer's disease testing. And both groups were interested. The post-symptomatic was like 95% yes, definitely yes, probably yes. And then with the pre-symptomatic, you still have a combined 91%, which is a vast majority of people saying, I'd be interested in that. Again, this is different. This is a change in what we have heard and seen previously. Next slide. So why did people say that they wanted to get testing? So we asked them, what's the motivation here? And the number one reason that we see here at 83% is that it would allow for earlier treatment and care. If you're not familiar with the new class of medications that have come out, they are indicated for very early, ideally MCI, mild cognitive impairment, or early Alzheimer's. And so if someone is diagnosed, sadly, if they're diagnosed in the middle or later stages, these new types of treatments are not they're not going to be eligible for them. So to see that lining up is a wonderful thing, actually, because they're right. It would allow for earlier treatment and care. They also indicated 76% indicated that it would allow them and their family to plan better for the future. And then at 68%, it encourages action to preserve existing cognitive functioning for as long as possible. You can look at the full report to see all the things that people see in it. But again, it's really wonderful to see that people are identifying things like I can address safety, I can get support and education, I can rule out other conditions. There's all sorts of reasons why people want to get testing. And so it's not just one thing, but a whole host of reasons why our survey respondents indicated desire to test. The next slide is about what are the concerns about testing. And I mentioned this before that 44% expressed concerns about insurance not covering future care. Also, some concerns about test accuracy. And then number 3 was, I might lose confidence in my ability to do things like driving, or it may put my job in jeopardy. So while we see these numbers, 44%, 41%, and so on, what we're also seeing the flip side of that is actually people were more positive about it than negative about it. So not to diminish these concerns, but still they were overwhelmingly positive in the face of even having these concerns. Matthew? So the next one is around interest in management and treatment. And so what we were asking about is what kinds of approaches would they want to take if they did find out that they had Alzheimer's? And so what you see at the far left here is that 94% indicated they would probably or definitely want medications to reduce disease-related symptoms. Okay, so again, that would be akin to perhaps the drugs like donepezil or the symptomatic treatments that have been around for a little while. The next column would be slowing the progression. Okay, so that's the newer class of medications. And what we saw there was 92% of people indicated that they probably or definitely would want a medication to slow disease progression. 90%, the next column, indicated they'd want education to support changes in their lifestyle. And maybe that's to, maintain brain health or even include adaptive responses to having Alzheimer's. 75% expressed interest in counseling and psychotherapy, and 71% indicated an interest in community resources, including things like classes and support groups. So in the next slide, I want to share a little more about that risk question that we asked, like how much risk are people willing to take? And what we can see here is that nearly 3 in 5 individuals indicated they would accept moderate risk or higher in order to slow the progression of the disease. So what we see is really these 3 purple bars in the middle here. Those are the ones that we're adding up. So a smaller number said, we had 14% who said, I'll accept very high, 8% high, and then 36% said moderate amount of risk. So that's where we get that 58% number. So you can see that of those who are perhaps not willing to take the risks. 27% indicated they'd take a low amount of risk, and 3% said, I really don't want to take a risk in pursuing medications. Now, why is this important? Well, things are actually developing around what even are the risks associated with these medications. I think we're learning a lot about what the side effects are, how to manage them, who's at greatest risk, and also perhaps the future may hold some different ways for drug delivery that may reduce that risk. So seeing that people are okay accepting a moderate amount of risk, that really may bode well for future opportunities where with any of these treatments, there are risks like there are for other conditions. Next slide. So here's some other treatment-related insights that we pulled from the data. Almost 3 out of 4 indicated that being able to take medication to slow the progression influences their feelings about an early diagnosis. That is not a surprise to me, and I bet it wasn't a surprise to Matthew. So many times I've stood in front of an audience, 200 people, and this is pre-treatments, meaning pre-disease modifying treatments. And I've asked, how many of you would want to know if you were going to get Alzheimer's? And not that many people would raise their hand. And I'd say, how about if I had a treatment that you could take, how many of you would want to know? And almost everybody raised their hands. And that's essentially what we are seeing playing out here is now as we shift into what we're describing as an era of treatment, we see a shift in attitudes. So it's not too surprisingly. If you can't do anything differently, why would you want to know? You can do something different now. And so people are expressing interest in knowing. So almost 75%, 74% indicate that outpatient treatment, at least monthly, would not diminish their interest. And for some of these medications, it's monthly or it's more than monthly. It's twice a month or every 2 weeks. So seeing that there's still interest, even though there's work involved in these treatments, was interesting. And then 83%, 4 out of 5, indicated they would be willing to participate in a clinical trial. So you researchers out there are people interested in getting involved in this and trying to see what we can do to address Alzheimer's. 4 in 5 Americans believe that new treatments are going to emerge in the next decade, and 66% believe new treatments to prevent Alzheimer's will be available. And we all hope they're right. Who knows? I wouldn't bet against it, I'll tell you that. It's looking so promising. So, next slide. So these are the high-level implications of this report. It's really wonderful to see the shift in attitudes towards early detection, diagnosis, and treatment. In particular, looking at the research to validate this, what we need to do now is to get to the next step in advancing biomarker testing. And I've learned a lot about this. I thought, yay, we have an FDA-approved blood test. Or there. No, actually, that's not true. We have to have validated approaches, and you also need to have guidelines for how will that testing be used in practice. So clinical guidelines are absolutely critical in order for us to be able to use these responsibly, ethically, and appropriately with the right people. It's been interesting to watch people who are sometimes in academic research settings where I work with a lot of people with a diagnosis or through that process, and they'll say, I got a test, it was a blood test. I don't really know what it was for, and I'm not really sure how they know, but they're saying ... And so I think for us to really understand what, and for patients to understand what was the purpose, what was the outcome, and what are the implications of these tests, we have a lot of work to do there. So creating those clinical practice guidelines is already underway, and we just reported on that at AAIC around blood biomarkers. And this is an area that's crucial that we invest in to make sure that when exciting things happen in the world of research and when the FDA approves things, that there is a pathway for people to actually, hopefully in relatively short order, get access. Presently, that is not the case. It takes time to get ready for that. And that was also true for the treatments. If any of you have had experience with that, it was a little rough to try to get access to treatments in community. We also see the need to improve the physician-patient conversations around testing, diagnosis, and treatment. And Matthew made such a great point about the shift towards primary care being even more involved in this because of the shortages in staffing. So we know this is crucial. We also need to look at the ethical concerns of early detection and what is it going to mean? What does it mean if you get tested and you're asymptomatic, but you have been tested for Alzheimer's? And also to work on advocacy around laws and policies that require insurance coverage of tests and ideally treatments. But right now we're starting with tests to see these blood tests as they come out, are they even going to be covered and available? And then last but not least, back to Matthew's point around public health. Public health is such a crucial part of this. We just reported out on US Pointer. Look that one up. Pretty exciting to see the results of that landmark study. But it does look as though we can do things in our daily lives that could potentially reduce the risk of cognitive impairment in later life. And so seeing what we can do to educate the public around risk reduction, and then accessing a timely diagnosis or even an early diagnosis, treatment, and care. So this is what we're focused on. Next slide. All right, and now I'm going to do a commercial break. So I was thinking about this, and I want to thank our friends at GSA because you all have been just wonderful to work with, and we're so grateful to be invited. The Alzheimer's Association just launched a new app, and it was my baby. I got to launch it, although it didn't come from me. It came from our early stage advisory group who said, could you create something to make it easier after a diagnosis to get early stage information. So I want to invite you all, you're welcome to download it and share it if you do clinical work or if you have friends or family affected by Alzheimer's. It's called My Alz Journey. It's free, My Alz Journey, no spaces, and it's available on the App Store and on Google Play. And it makes it easy for people to get quick access to very warm and welcoming testimonials and videos of people living with Alzheimer's and other types of dementia, and also get access to resources through the association. It is an early stage program, though, so it's not for people in the later for caregivers in the later stages, but it's an excellent resource for care partners in the early stages and people with the diagnosis. So I hope you'll check it out. That's my shameless plug for free app. And with that, I'll turn it back over to Lisa.
Great. Thank you, Matthew and Elizabeth. This was excellent. Lots of great information, and definitely a great follow-up from the AAIC meeting last week. So we've got some questions in there. So Elizabeth, to give you a chance to catch your breath for a moment, I'm going to go to Matthew. And so Matthew, the first question I'll throw out to you is, what data sets were used to estimate ADRD cost burden?
Yes. This was the cost burden is a model that was built for the Alzheimer's Association by the Lewin Group, which is an econometric firm that's based in Washington, D.C., and has offices in California as well. And they modeled the cost of the disease and the population with the disease using a variety of inputs, including data from Medicare claims files, from the Medicare Current Beneficiary Survey. It uses data from the Census Bureau in terms of where the population demographics are headed. Those are the big inputs. There is in the appendix note of facts and figures. There's a little bit more detailed explanation of the cost model, but it's basically taking the data that we're able to reach through Medicare Current Beneficiary Survey, Medicare claims files, and then plugging it into a model, recognizing the important point that it could be as many as half of people with the disease are not diagnosed. So Medicare claims files are not picking up diagnosis. And that's one of the things the model is designed to address, is accounting for costs of those who do not have a diagnosis.
Okay. Thank you very much. Elizabeth, I have one for you. So where can I learn more about the clinical practice guidelines that you mentioned?
Yeah, actually, great question. So we have some publications that we can share, and Matthew actually knows probably even more about this since he's been working with these groups over the years. But so the blood-based biomarker guidelines are in process, as I understand it, and so those will be. Those are in flux, and actually the new emergence of blood-based biomarkers are making it very interesting too, to see what is it going to take to achieve the level that we need in terms of evidence and strength there. But also we do have, there's other clinical guidelines, clinical practice guidelines that would be of help. Matthew, what do you recommend in terms of the best way to access those for those wanting to see?
So I think you can go to the association's website. There's a sublink that is too long to state here. We can have folks send it out afterwards, but you can go to alz.org, and then in the search bar just type in clinical practice guidelines, and it'll talk about the guidelines that are in process, as well as links to drafts that have been released to this point. That's probably the easiest way than for me to read off about 100-word URL.
All
There
right.
may also, can I add one thing too, Lisa?
Mhm.
The Alzheimer's Association just launched a new initiative called Alz Pro. And in Alz Pro, there are actually sections that you might want to check out because the guidelines are also in there. And as Matthew was alluding to, so you'll find some free classes, workshops, including more content on the guidelines.
Awesome. Thank you very much. Matthew, I think this one is for you. So when referencing Alzheimer's disease being a leading cause of death, is that just Alzheimer's disease or does that include other dementias related to it?
So this is a very good question, because it is something that I have struggled with the way, Lisa, your old employer does this in the United States. So in the United States, the rules and processes for classifying and ranking causes of death means it is just Alzheimer's. So if somebody on their death certificate, it says dementia or vascular dementia, it is not in that 120,000 number. If you add in those numbers, that 120,000 more than doubles. And if you said, if you ranked, and it doesn't work this way because of the CDC rules on what is a rankable cause of death, that could be the subject of an entire webinar in and of itself. But if you were to count all dementia deaths recorded on death certificates, and if you were to rank that, it would be the third leading cause of death in the United States. Most other countries in the world do it that way, which is why if you actually look, you'll see in the UK, dementia is the #1 cause of death. Now, the other thing the UK does is, unlike the United States, which combines all cancers, the UK separates out and classifies all cancers separately, which is another reason why dementia is #1 in the UK. But that 120,000 figure that I cited for you was just Alzheimer's.
Okay, great. Thank you. Elizabeth, I got another one for you. So somebody was talking, so when we talk about the disease modifying therapies, insurance may cover them, but the question is, even though it might be covered, what kind of out-of-pocket costs will people see, and are they really affordable costs?
Yeah, that's a great question because I mean, for the current treatments that are available, people can be paying quite a bit out of pocket. The estimates would be in the neighborhood of 26,000 a year for at least last I heard for one of the medications. I think the other one is pretty similar. So many people, can't afford that. Absolutely true. Absolutely true. So we're not at the place where these medications are available for all. They're not even available in all communities. So even if you have the money, you're like, this is the rainy day for which I have saved. Um, you may not be able to access them in your community very easily. The other cost that can be quite burdensome is around the testing, and I don't mean testing for a diagnosis, although that can certainly be expensive too. But they do require regular MRIs, and you have to get an amyloid PET or other types of tests. And so what we're witnessing is a lot of struggle for families to figure out, how do I get it? Will my insurance cover it? And can I even afford the copay? So want to be in terms of people really being able to afford these and access them, but it's the beginning, and hopefully it will get better as more options appear on the market.
Mhm.
Lisa, could I just add to that? I just wanted to underscore, uh, so two things. One, the 26,000 approximately, that's the total cost. That's not the out-of-pocket cost. That's the total cost. So
Okay.
the patient share would be
Oh, the
the cost
copay.
sharing of that. Yeah. But the other thing I just wanted to note, I'll put in a plug for, not meaning to do an advertisement for the insurance industry, but we did some analyses a couple of years ago when the drugs were first being reviewed by the FDA, and we found that people, if they have a Medicare supplemental policy that they purchase, would have zero to almost no cost sharing on these drugs. So that because most supplemental policies will cover that fee. So it is a very expensive proposition, as Elizabeth noted, but excuse me, there are ways to help alleviate
Around
some
that.
of that burden.
Thank you for adding that. That's very useful for our audience. So another question, I think this is probably a both, or maybe one of you want to take it. So how's the Alzheimer's Association working with employers to ease fears around employability of individuals with early diagnosis and or biomarker positives?
So the question is about employees with cognitive impairment. Yeah, we actually just last year did a white paper on that topic in partnership with Bank of America, looking at it internally. That's a new area, I have to say. Not many people are talking about that. Like, what do you do if someone starts to experience cognitive challenges in the workplace? But we are just kind of getting started and looking at, what should HR do? What should individuals do? And I'm learning, this is just me speaking, so not on behalf of the association. What I've learned so much from people, especially younger individuals with young onset Alzheimer's or other types of dementias in the workforce, that so often people quit or they get fired and when something starts to happen. And there have been a few instances where friends in the workplace said, there's something here to protect you. It's called FMLA, and you need to actually start that process. And so just being open and sharing with people that if you think you have cognitive issues, use the benefits, use the protections that are there for you as you figure out what you're going through. Because if you lose your insurance, and sometimes individuals were there and providing the insurance for their whole family, we've just seen some of these instances where it went down a pathway that was really, really difficult for people. So I think there's a lot more work to do in this area, and not many people are talking about it yet. So, Matthew, did you have anything
Nope.
you wanted to add? Okay.
Okay. So another question, this one's focusing a little more on prevention. So how are insurance companies separate from Medicare and Medicaid reacting and supporting the need for more preventive care?
So I think this is Elizabeth talked about a new area. This is really a new area as well. The science on prevention, on risk factors has really evolved over the years and has really started to get um, strong enough to the point where we're comfortable, much more comfortable than we have been with the science in the past in talking about things that can be done to keep your brain healthy. This was underscored by Elizabeth mentioned the U.S. Pointer trial, the top line results of which were announced last week at the Alzheimer's Association International Conference, AAIC. And that was an actual specific intervention. It was a multi-domain intervention in which clinical trial participants engaged in exercise, diet, cognitive engagement, as well as heart health monitoring. And that showed significant benefits of participation in that intervention. And these were people between the ages of 60 and 79 who had elevated risk factors. So this is all just kind of new and evolving. And one of the things we are actually working on is what can insurance companies, what can payers do? In fact, the association is holding in a couple of weeks something what we call the Payer Summit, where we have representatives from multiple different types of payers, whether they be insurance companies, HMOs, Medicare Advantage plans. These include insurance plans that cover people before they're the age of 65. These are private insurance plans. And one of the subjects that we're going to be talking about is some of the things that payers can do to address risk factors for dementia. The dilemma that we have in this space is that a lot of the things that you would do to reduce the risk, keep your brain healthy, are going to accrue after the people go on Medicare. So if I'm a private insurance company with a bunch of 40 and 50-year-olds, anything I invest in brain health and reducing risk of dementia, I'm not going to see the benefit, or I'm unlikely to see the benefit of, unless those people enroll in my Medicare Advantage plan if I offer one. The flip side of that is the good news. Everything I'm going to tell you to do that payers should be doing, that payers should be focusing on, are things that will have a long-term benefit for dementia, but have a very short-term and positive benefit for physical health. So I'm going to tell you to control hypertension. I'm going to tell you to prevent and control diabetes. I'm going to tell you to prevent and control obesity. I'm going to tell you to quit smoking. I'm going to tell you to exercise. I'm going to tell you to eat right, right? And all of those things have much more immediate benefits, much more immediate return on investment, so to speak, for insurance companies. And so the key is getting payers, insurance companies, to understand that doing positive preventive measures for brain health has immediate return or short-term return on investment. So they don't look at, well, by the time any money is saved, they won't be my patients, they'll be Medicare's.
Well, Dr. Edgerly and Matthew, I want to thank you so much for participating in GSA's webinar series today. I want to encourage all participants to make sure they complete the evaluation, and we look forward to seeing you in future webinars. Thank you very much.
Thank you.
Thank you. Take care.